So we're going to move on to the next speaker, which is Professor J.KELLUM from University of Pittsburgh. And John is one of the most famous experts in this field. And he's going to talk about the pathophysiology of perioperative AKI. John?
Thank you, Tom. It's a pleasure to be here with you, even if it's virtual. I, like most of you, are extremely tired of saying that, so hopefully things are moving in the right direction and we can start doing these meetings in person again. And I can see, and if we do it in person, I'll be able to sort of see how you're following this talk. So. I'm going to talk about the pathophysiology of perioperative acute kidney injury. My disclosures are shown here. I'm currently on leave of absence from the University of Pittsburgh, which is my academic post, and serving as Chief Medical Officer for Spectral Medical and their wholly owned subsidiary, Dialco Medical. And I'm also a consultant for several biotech companies, and I will not be talking about any of the products that these companies make. All right, so I want to begin with where Max had sort of left off, which in terms of talking about the epidemiology of acute kidney injury. I want to remind you that acute kidney injury is a syndrome, not a disease. And it's caused by lots of different things. So and many of these can cause perioperative acute kidney injury as well, and many of them are specific to perioperative medicine. But these different syndromes have a difference in prevalence across different settings. So in abdominal surgery, for example, or vascular surgery, we see abdominal compartment syndromes. We see cardiac surgery associated AKI, obviously, in cardiac surgery, along with cardiorenal syndrome. Virtually all forms of AKI have a contribution to various nephrotoxins, and I'll talk more about that in a minute. And these various forms of AKI, if you will, cause acute kidney injury in very different ways. There are some common themes that I will discuss with you, but it is important to recognize that when you have acute kidney injury, even though the clinical manifestation is a rapid decrease in kidney function, the underlying mechanisms that drive this decrease in kidney function can be very different, and therefore result in or require different therapies and have different prognoses. Now, it's tempting to believe that acute kidney injury is not this complex, and I think, unfortunately, the training over many years for doctors has not necessarily provided a sufficient nuance. When you turn to the chapter on acute kidney injury or acute renal failure, you find the complexity that I just described. But in practice, many people fall victim of the fact that the most common forms of acute kidney injury that are listed for you here, sepsis, major surgery, cardiogenic shock, and hypovolemia, all can present with shock. And therefore, it's tempting to believe that acute kidney injury is all related to under-resuscitation, and that the treatment for all forms of acute kidney injury is to give fluids. And this has resulted in a practice pattern that I would say is often wrong and sometimes dangerous. And this concept of treating all acute kidney injury the same is decidedly counterproductive. And I'll show you an example of that, a patient that I took care of recently when I was practicing in a cardiothoracic ICU service. This is a patient who's post-op day 4 from mitral valve repair. She was readmitted to the ICU on day 4 with respiratory distress, and she was intubated. Her chest x-ray showed bilateral pulmonary edema with possible bibasilar infiltrates, worse in the right than the left. She had a BAL that was sent. She had a fever and an increased white blood cell count, and this all began about 24 hours earlier. She was started on antibiotics. and her serum creatinine, which at baseline had been 1.1, post-op day 1 was 1.3, and now was running at 1.7. Her urine output was low, and her fluid balance since the surgery was 6.2 liters. I had to fight to keep this patient from receiving additional fluid resuscitation. The canonical therapy for this patient in the cardiac thoracic surgery service was to shoot first with fluids and ask questions later. I mean, it's remarkable. Here's the data. How could you possibly consider this patient as requiring additional fluids? And if you thought that they might require additional fluids, I think the onus is on you to prove through hemodynamic monitoring that this is a patient who requires additional fluids. So clearly, as though we may know somewhere in our consciousness that acute kidney injury is caused by a variety of different conditions. In this case, it may well have been due to an inflammatory process outside the kidney, or to various nephrotoxins, etc. We know this somewhere in our brain, but we operate as though we didn't know this. And it reminds me of a scene from the movie Men in Black. This is where Tommy Lee Jones's character, Agent K, is explaining to the soon-to-be Agent J, Will Smith, after it was revealed that there are aliens on Earth, that he says, 500 years ago, everybody knew the Earth was the center of the universe. And 500 years ago, everyone knew the Earth was flat. And 15 minutes ago, you knew humans were alone on the planet. Imagine what you will know tomorrow. And I think this is the problem. I think we all know that acute kidney injury is a problem of under-resuscitation, and we resuscitate patients and we don't really think about it. And of course, this is our therapy in the ICU too often anyway, right? So for virtually everything, we think that saline is the treatment, and then we consider other treatments next. This list, by the way, reminds me of a cartoon from Gary Larson many years ago, where the treatments were just as nuanced. Now, I say all of this somewhat tongue-in-cheek, but it's, as Max was alluding to, it's really not so different in the real world, and we have to do better. And Marlise and John will be talking to you about that. So what if it's not just under perfusion, what is going on in acute kidney injury, and how can we direct our therapies to it? So this is just to give you some sense, even in a rather narrow portion of perioperative AKI, cardiopulmonary bypass, just how complex it can be. So the circuit bioincompatibility will activate complement and inflammation. There's hemolysis, which leads to free hemoglobin and catalytic iron. There's decreased tissue perfusion. In many cases, it's more important outside the kidney, although there may be direct hypoperfusion to the kidney in certain situations. The kidney actually tolerates hypoperfusion very well. Remember, the kidney is the only organ that we transplant, of the organs that we transplant, it is the organ that is most resistant to ischemia or perfusion injury. I mean, we could cut this organ out of a dead person, put it in a bucket, and transport it across the country and sew it into a recipient, and usually it works pretty well. Now, I'm trivializing that a bit, but we find enormous ischemia reperfusion injury in our lung transplant patients. Kidney injury, kidney transplant patients, they generally do pretty well. But the tissue hypoperfusion that occurs outside the kidney causes release into the circulation of various damage-associated molecular patterns, including myoglobin, uric acid, HMGB1, all of which can directly injure the kidney. And this extra renal ischemia may be much more important than the direct effects on the kidney. And then in cardiac surgery and in other surgical procedures, our direct injury to the kidney from RV dysfunction, venous congestion, is also a major factor. Now, this is just the differential diagnosis in the setting of cardiopulmonary bypass. If we expand this to all surgery, it looks more complex, and I'll get to that in a second. And then there's our treatments, and even our treatments treatment of choice, which is saline, has problems. These are studies which have compared saline to balanced solutions, and both of these studies have indicated that there's a small but statistically significant effect on the combination composite endpoint major adverse kidney events, which is doubling of serum creatinine, renal replacement therapy, or death. And you can see under both circumstances, whether it's low-risk patients or high-risk patients, the overall event rate is lower, but the differential effect, the effect size, is very similar when you switch to balanced fluids. Now, there have been subsequent studies, and I should really have updated the slide to include the PLUS study and the BASIC study, but a recent meta-analysis has really demonstrated again that there's a very high probability that saline is associated with an increase in adverse kidney events and affects outcome. Now, if you bring in the full complexity of this process, you draw cartoons like this. This is from a paper that John Prow and I wrote a couple of years ago. And if you sort of focus in on this, so it's a little easier to look at, you recognize that infection and major surgery are similar in many ways. There are processes which are specific to major surgery, such as anesthesia, blood loss, in addition to fluid losses, cardiopulmonary bypass, obviously selective to procedures which involve it. And then there's tissue injury, which leads to the release of those DAMPs that I spoke about, those damage-associated molecular patterns. But, infection causes tissue injury as well with release of DAMPs, and there's also release of pathogen-associated molecular patterns, or PAMPs, and both of these stimulate the same molecular pathways that lead to inflammation. We also have antimicrobial drugs. We can have direct effects on the kidney through redistribution and perfusion away from the renal medulla. We can have elevated intrarenal pressures related to back pressure from RV dysfunction and fluid overload. But these conditions overlap significantly, and therefore it is reasonable to think about perioperative AKI with or without infection in a similar way, well, not identical, but in a similar way as we think about sepsis-associated AKI. And if we drill down further and we look to see what happens to these molecules as they are delivered to the kidney, both through filtration at the glomerulus, because they are filterable toxins that then directly interact with toll-like receptors and other pattern recognition receptors on the renal tubular epithelial cells, particularly in the proximal tubule, which is the first place that sees these filtered molecules and has a very complex and well-defined or developed, I should say, a response to these molecules, leading to inflammation in the kidney, as well as other responses and decreases in infiltration through tubular glomerular feedback. We have all of this going on on the epithelial side, but also on the endothelial side. These molecules are delivered to the kidney this way. They interact with both circulating and resident immune effector cells. They cause injury to the endothelium. They cause injury that is mediated through immune effector cells and their interaction at the microcirculatory level. The transit time through the kidney increases as immune effector cells become essentially clogging the microcirculation, and as that's occurring, there is not only a decrease in oxygen delivery, which the kidney actually tolerates reasonably well, at least for short periods of time, but there is also massive increases in the inflammatory response. So all of this is happening, and none of this is reversed by giving patients increased fluid when they don't need it. And so our patient status post mitral valve repair, who is 6 liters positive, had all of this going on and not merely a deficit of circulating blood volume. Now, there's also a timing issue. So 41% of all of acute kidney injury occurs in the perioperative space within the first 48 hours. And when it occurs later, and I should also mention that as much as 13% or more of acute kidney injury in these patients actually is present on presentation before the surgery. It's often missed, frankly, and you can imagine why that occurs, right? If we're talking about cardiac surgery, these patients often have undergone contrast studies. They may have been unstable with myocardial infarction. They may have received balloon pumps. All sorts of things are happening to these patients even before they get to the OR. If we're talking about general surgery patients, abdominal surgery patients, for example, these patients may have infection. They may have dehydration that complicates. And just a quick word about dehydration, because I should have mentioned it on the prior slide. It's important to recognize that volume itself, lack of volume, does injure the kidney in the extreme, but we're actually very well designed to tolerate periods of dehydration, and even reasonably well designed to manage brief episodes of hypovolemia, which is of course different than dehydration. But when this is prolonged, or when it is combined with nephrotoxicity, whether it's from an exogenous or endogenous nephrotoxic substance, as I've just shown you, this definitely adds to the burden of injury to the kidney. So it's not so much that lack of volume is causing kidney injury in many circumstances, but it's adding to the injurious process. So when you look at the distribution of variables that are associated with these with kidney injury, early versus late, you see that early acute kidney injury is largely a function of what the patient brought to the table, their underlying demographics and comorbidities, but also their surgery itself plays a major role in the development of acute kidney injury, whereas late acute kidney injury is often more a function of the things that happen to patients after the surgery, and things like patients' ongoing requirement for vasopressors, and their exposure to non-steroidals, and their fluid balance, and whether they develop sepsis, are all very much predictors of acute kidney injury late, whereas the surgery itself is much more of a factor when we're talking about acute kidney injury that occurs within the first 48 hours after surgery. So why does acute kidney injury occur? Well, sepsis-associated AKI is a damp, PAMP toxic nephropathy, and surgery-associated AKI is very similar. It's a damp or a toxic nephropathy, and it's complicated by other toxicities, antibiotics, contrast, pay particular attention to certain medications such as vancomycin and piperacillin and tazobactam. These and the combination of these two antibiotics are clearly associated with a lot of acute kidney injuries. Fluids, ladies and gentlemen, can actually worsen AKI, and so you really have to be cautious about your use of fluids in these patients. Giving more fluid to a fluid overloaded patient whose right heart's struggling already is a recipe for worsening kidney injury, not treating it. Resuscitation, of course, remains an important part of therapy, and I certainly don't want to discount that, but we got that right. We've just overdone it and tend to give fluid when it's not needed. And don't use saline. If you're going to select a fluid, use a balanced fluid. There's no reason to add iatrogenesis. I admit that this is not a huge factor in most circumstances, but why even increase a patient's risk by 1 or 2%? Right heart dysfunction in cardiac surgery and intra-abdominal hypertension in abdominal and vascular surgery are major causes of AKI as well. Early, within the first 48 hours to 60 hours post-surgery, and late AKI are quite different. And don't forget that many patients actually already have acute kidney injury that starts prior to their surgery. And so with that, I thank you for your attention.
Well, thank you very much, John. we have time for just one question because we are running a little bit late. So, when we are in the operating room, sometimes we have oliguria. It's extremely difficult to interpret this oliguria in the OR because there is this release of the antidiuretic hormone triggered by the surgery by itself. So what would be your advice to this anesthesiology community who is listening to us right now about this intraoperative oliguria? Because sometimes maybe the best is just to not do anything. I've seen so many things done just for this oliguria, and I'm wondering if it's maybe worse to do this.
Yeah, no, I agree with you. I think oliguria should always be an indication that you need to investigate what's going on. And if you're satisfied that circulating blood volume is adequate and appropriate, you should not give the patient additional fluid. Far too often, there's a reflex that goes from the Foley catheter to the IV bag, and we give fluid for reasons that are not evidence-based. And I would strongly agree with you that not just in the OR, but in the perioperative period, and then frankly, many other patients in the ICU, tend to get a lot more fluid than we realize, and they tend to be fluid overloaded, not underfilled. And so if a patient in the ICU, frankly, is in hypovolemic shock, you should be quite surprised, and you should be at the bedside investigating why this is the case. You shouldn't be just ordering IV fluid. So I agree strongly with your observation.
Okay, John, we would like to thank you very much for getting up early because we know you are on the West Coast, so it's early morning for you. We thank you very much for being with us today.